I replace a well-known British surgeon. He called me 1 week ago, so I didn't have so much time to prepare myself. But my background for anterior surgery is I'm an orthopedic surgeon. I'm since 20 years in the private practice, and I do anterior surgery 30, 40 times a year, so I did some 600 surgeries, anterior surgeries myself. The advantages of the anterior surgery we heard from Roberto. I think this I don't have to repeat. By the way, I have nothing to disclose. I'm just married. He gave me the difficult topic, salvage surgery. There we have to divide. If we go in a virgin anterior field, anatomical field, or if we go for a secondary exposure, that's a completely different thing. And that's I want to point out. I want to speak clearly about safetiness. We have some mism that this is a very dangerous, life-threatening surgery. I will give you some case examples and give you a literature review. So I already mentioned this. Primary anterior exposure actually is a good way for salvage surgery. I will show you this in a few cases after I come back to the secondary exposure for salvage surgery. These are the figures of Brow. He's a very specialized access surgeon. You see the complication rate is really minor. You see this 0.8 venous tears and so on. Even retrograde ejaculation is not a real topic for him. And he only do the accesses, and I learned in the Texas Back Institute how they proceed with the access surgeons, and that works very well. We did a prospective study to compare disc prosthesis, Pro discs, and Charité more than 15 years ago now. And you see we had approach-related complications in about 6% of the cases. But we were able to save the situation with suture, and we could actually solve all problems. Don't look at the implant-related complications. This is not the topic here. This we will present with the 10-year results. This is a first case. And you see, this was discectomy at the level L3-4. You see this local kyphotic deformity after this decompression with a recurrent disc herniation. So, what would you do? Pedro, perhaps we start a little discussion.
Yeah, may I have this mic on?
I think you know what I did, but...
Yeah, I think that the important thing here is consider what are the goals of surgery. And for me, the goals of surgery would be, in this case, eliminating the pain generator that I suppose the disc is. The second thing is to fix the sagittal deformity of this segment. And I would stress also the importance of correcting the coronal tilt of this segment, because in our experience, this is the first step of what's an evolutive and a progressive degenerative de novo scoliosis. So I think that the goals are to eliminate the pain generator and to realign in both planes. What do you think about that?
Yeah, this is the goal. So let's ask, who would do an A-lift for this case? Who would do an X-lift for this case? Okay. And PLIF, T-lift, I think. Okay. So It's about 30, 30, 30, huh? Okay. So what I did, I know you will know. In this time we didn't have cages with the screws going through the cage. So we just improvised it with a normal cage and put some cortical 4-point screws through this. And here you see, with this approach, you really can directly correct the local segmental deformity. And with the anterior approach at the same time, you create a very good bed for the bone transplant. You see here how the ingrowth of this transplant is, and here you can be sure you have a solid bony fusion. This is the sentinel sign, and that's why you know, even if the patient has pain after, you did technically a correct job. Next case. 50 years old male. He had decompression dynasis. He did very well 10 years. Then he had 2 years ago re-decompression. We just did this case a few months ago. He lost a lot of blood, and he had persistent predominant low back pain. Here you see the screw loosening. He had only in L4-5 intervertebral bony transplant. This was healed. The rest, there was a non-union with screw loosening. So we decided to do a 3-level anterior fusion with these cages where you put the screws through the cage. There is now quite a lot in the market that it's offered by the industry for this surgery. So this was our solution, and the patient did very well. He left the clinic for days after surgery. And I think that's the advantage in salvage procedures. We even didn't touch the posterior elements, not to destroy the already quite destroyed posterior anatomical structures. Then cage dislocation, that also happens to us. Perhaps this was a little bit a minimal fixation with the translaminar screw fixation technique. You see we have a dislocation of the cage. It was the wife of a referring doctor. It was not a comfortable psychological situation. So you see here the solution. We just did an anterior approach and have here the bony healing after half year. And here, that's a very crazy case. This patient came with this scoliotic deformity. She was fixed for spondylolisthesis. This was done well, and then she collapsed within 3 years. Unfortunately, I didn't find in the short time the slides before. That would be interesting, but I will follow up this. But this was the basic situation where we had to make a decision. And you don't see the cage there was a loosening of the cage in L4-5. So I had to remove this cage anyway. And I made a decision to go from the front, from anteriorly. And we started with 4-5. Then I thought, yeah, and then I changed my plan intraoperatively to go for the next level. Let's look what you can correct with this release. And at the end, I was on L1, L2. But this is not a general recommendation to solve scoliotic problems. That's just to show how creative you can be with the anterior approach and anterior instrumentation in salvage problems. So this is the summary. It's safe, like you told already, it's primary surgery, even if it's a salvage situations. You have a high patient comfort with the anterior approach because the pain is uncomparable low than with posterior surgery, even with minimal invasive methods. You highly promote the bony ingrowth, and as I told you, it's quite creative. I didn't mention this. I always have a vascular surgeon in the background in the clinic in case something happens. Of course, little tears I suture myself, but I feel more comfortable. And we also have to think more for the medical legal situation we have in Europe coming up, a real problem. And that's why I highly recommend the access surgeon. You must educate him a little bit before. He also must assist you in the normal surgeries so that he knows what you want from him and that he doesn't do these big exposures and that he's really prepared on the situation. And that's the concept, a team concept that makes it safe, the anterior surgery. Now we come to the re-exposure surgery, and that's a completely different story. And I think that's also the reason why many surgeons have fears in thinking on the anterior approach. Of course, we have scar tissue, higher vascular risk to have vascular and visceral complications. I looked in the literature last week, only 8 reports. And of course, usually for the total disc replacement with all these FDA studies, comparative studies. And of course, we have then to wait in the potential complications with the benefits through this approach. And as I mentioned, I think if there is no clear algorithm for this situation, this salvage situation, where you have to do a revision exposure, you will have doubts. So this was one of the representative studies I found from Schwendern, from the Twin City Hospital in Minnesota, Bob Winter and the Transfeld, one of the most famous names there. They had a large number of patients, procedures, as you see, 115 in 108 patients. They divided in 2 groups, same level, that's what I speak now. Adjacent level, this what was what I showed you before, or let's say these are still virgin levels, but it's of course a revision anterior lumbar body lumbar approach. They have access surgeons, they did all the surgeries, and they were also present in the revision surgery. So this makes this study quite strong. They all had posterior instrumentation, that's why you see quite a lot of also other complications. They are not related to the anterior approach. Here, let's look to the complications. Index level, we have 52 patients in this study. We had venous tear, 25%. But if we read exactly the paper, it's between 250 and 1,400 milliliter blood loss. When they have blood loss of 250 milliliters, they speak already from a major complication. So we also have to ask and define the complication. I think there we have, in the literature, a problem, and we have to start to define the complication, like in Esperanto language. So, no arterial tears, that's also my experience. Keep attention not to retract too long, like in the extremity surgery, not more than 2 hours, then release. You can also put an oxygenometer at the great toe, so you can observe this arterial problem. In this group, there were 2 urethral injuries and 5S1 related retrograde ejaculation, quite high amount, 10%. unable exposure, where they had to stop because the risk was too high, was in 25%. I don't know if this is a complication. It's just a change of strategy. And so don't count all complications together. So it looks awful. It's not so bad as it looks. So the main problems, of course, are at level at 4, 5. That's the difficult level, most difficult level. And they pointed out no deaths or arterial injuries, and of course no adequate exposure in 15 cases. These were the approaches they used. This was a big surprise for me. In about 60%, they used a left retro, again after left retro, even in presence of scars. They had one right retro peritoneal approach and did it again. Then retro peritoneal to transperitoneal in the secondary approach, and that's what we recommend. That's the most safe approach in a secondary revision situation. So that gives you quite an overview how sure these access surgeons were about themselves and how confident they were with the anterior approach. That speaks for the access surgeon you have to take to you. So here you have a case. This was a patient, it's more than 10 years. I operated for recurrent disc herniations, and she came a third time, and with the discectomy from anterior, that's also possible that you can do a nice decompression from anterior. And you see what happens after 14 days. And interestingly, it was the whole body. It was not the prosthesis. Do you see? She had a retrolisthesis, and she actually she reduced this retrolisthesis. So, question to the audience: what would you do?
Can you open this microphone? Who would do just a posterior fixation and arthrodesis? First option. Okay, 14 days post-op. Second option, who would do an anterior reapproach and fusion? Okay. Any crazy guy would do a new prosthesis? Okay.
So you want to say I'm crazy, yeah? So, I mean...
I'm sorry.
That's why we like each other. So it was 14 days after primary surgery, and the tissues were still fresh, and she was 45, and I couldn't do fusion.
This is a more constrained prosthesis.
Yes, of course. That's a customized prosthesis. This is some customizing of prosthesis. So that was this. Then here I have also a prosthesis case 10 years ago. He had an accident, brain injury, and nobody took care about his low back, his lower spine, and he had this luxation of the polyacylene core. It didn't show the CT scan, angio CT scan that we do. It was no compression because it was in the middle of the bifurcation. So actually there was no really strong need to just for this to operate him. It was the pain and of course the loosening of the prosthesis that you can see here on the end plates. And we did this again, this anterior approach, transperitoneal, as I told, in a secondary apposure of the index or the same level we do transperitoneal together with an access surgeon, and you see the result. There's a prosthesis, he's doing well, and you see this fantastic bony bridge anterior of the cage. This is another case. That's what we see now more and more with the Charité prosthesis after 10 years. The core is too thin, and there's a thinning and rupture of the core, and we see such situations. She had pain, and you see the CT, the angio-CT, didn't really help so much, and I think it doesn't really help you. The situation in the operation is different, and in this case we couldn't manage. It was too dangerous for me to continue, and we changed. I put in the polyethylene core, but he came out again when we turned the patient, as you can see here. But because there is no relevant compression to the vessels, we can leave. We did a bone effusion transpeduncular fixation. This is a non-union and infection case you see here. Spondylolisthesis, ALIF, then subsidence, posterior fixation, and then infection. So we had to go inside and do a second anterior approach. Exposure at the same level, transperitoneal. Here you see the result. We did the reconstruction of the anterior column with Harm's cage, bone cement, and autologous bone graft. And you see the result. We could solve the problem. The last case, this is a 50-year-old male. He became a friend of me because I did 20 years ago. He was 30, I also was a little bit younger. An ALIF and the posterior fixation, as you can see here. He had 2 discectomies already, he's 30. And he did very well. Then he came with an stenosis. We decompressed, and now he came back with predominant, massive low back pain. You see the visual analog scale values 6 to 8. And so we looked at the pictures, and we see this discopathy. He had also spondyloarthritis on these levels here, 2, 3, 3, 4, 5, 1. So Pedro, what would you do? Some crazy things?
Okay, I again pass the ball to the audience. I will not make any statement. And in this case, how many of you do surgery only on the most stenotic level from a posterior approach? Okay, 2 levels above the fusion with the posterior approach? No one. 1 anterior approach for 1 level? No one. Conservative care. 2 anterior levels? Just discectomy. What are you doing in this case? Swimming.
I have to tell you, he had no neurocompression, and he had no radicular problems.
Okay.
He really had intractable back pain, and he was desperate.
Okay.
So we did this. We did a 3-level fixation or implantation of pro-disc prosthesis. It's also for me personally a renaissance. And I tried on this way to solve his problem. This was a redo. Of course, this was Virgin's levels, this 3. And here, one surgical remark. If you do the first surgery, you have to look that you keep the upper and lower level virgin, so that you don't prepare too much up and down. And especially on the L5S1 level, you should go from the right retro, because like this, you keep the left side virgin. So that's a very important surgical remark. This is our recommended algorithm. I don't repeat, I say just index level, re-exposure, transperitoneal. If you go for a different level, you usually can go retro. So that's my message. The primary revision cases with virgin planes, I think that's like Roberto told the same situation, efficient, high patient comfort, but access surgeon in the background. Secondary exposure in revision is highly demanding. You need the surgeon, the access surgeon at your side. That's what I recommend and how I feel comfortable. Extend the approach and control the vessels already before up and above and below. And we recommend the transpattern approach. And how I explained you the complications in these secondary approaches, it is controllable and feasible without fatal complications. And that's why the myth that this is a life-threatening surgery is not true. I hope I could fulfill your expectations. Thank you very much.